Oh my goodness. Hi.
Oh, there's Sheila.
Jasmine, should we get started or should we give people another couple minutes?
I think if folks who are attending could just hold on a moment, we'll start in a couple of minutes.
Excellent. Good afternoon, everyone. Everybody settled in their favorite Zoom spaces. I am Kelly Hall. I'm the Senior Director of Healthcare Transformation and Innovation. And on behalf of myself and my colleagues at the Health Policy Commission, let me welcome you to what I hope will be an informative and interesting discussion of the role of emergency departments in initiating treatment for opioid use disorder. We have a lot of content to share with you today, so let me get right down to business. To ensure that everyone is starting with the same knowledge base, we're going to start today with a brief presentation from Cindy Thomas and Maureen Stewart of the Heller School of Social Policy and Management at Brandeis University that will orient you to the goals and to the findings from our Shift Care investment program. which supported hospitals in implementing OUD programs in their emergency departments. Cindy and Maureen were deeply involved in evaluating these programs and not only have incredible content expertise in this area, also have really deep experience with the different awardees in their program. So I know it's going to be a great discussion. From there, Cindy and Maureen are going to moderate a discussion with an incredible panel of shift care awardees from around the Commonwealth to share their experiences in implementing OUD programs in the emergency department. Speaking for myself, I love these kinds of discussions because I learn so much when panelists can talk to each other and respond to each other rather than simply presenting didactically. That said, just because we're on Zoom does not mean there is no opportunity for class participation. We will have the chat function open, so please use it as a place to pose your questions or offer your thoughts. This will be a lot more fun, and I guarantee a lot more informative if all of you are involved to the extent that you're able. So this is going to be a busy 90 minutes. We have a lot to share with you, but to get us off to a solid start, I would really like to stop talking and let the people who really matter have the floor, or at least the virtual floor, for a moment. And when I say that, who I'm speaking to are the providers, staff, and patients touched by the Shift Care program. So with that, let me turn it to Jasmine to tee up a brief video.
Thanks, Kelly. All right, this is a video that we developed. It is focused on the Shift OUD program, so I will just pull that up in a moment. Thank you.
Affected my community in a lot of different ways. It's a tragedy.
No one should die from an opioid-related overdose. We know how to intervene and save someone's life. We know how to treat the underlying condition of opioid use disorder. So it's really an example of how we haven't had the will to mount a response that meets the needs of the current crisis.
The Shift Care program was offered as a challenge to clinical systems throughout the state to see if we could do better vis-a-vis patients with opioid use disorders and in the hospital.
Funding supported 9 hospitals to be able to offer immediate access to medication treatment for opioid use disorder in the emergency department, link people to ongoing care and bridge clinics, and to build in peer recovery coaches as a part of the healthcare team. What wasn't working is that we weren't reaching the patients where they were at, and where they're at is in crisis. And that's where the bridging clinic and our approach, meeting them right in the emergency room and saying, you can come and see us today, tomorrow, right now.
The idea was to give those patients easy access to treatment, quick access, and a quick referral to outpatient services. Whatever work was started in the emergency room, we were able to pick up on outpatient basis and work with those patients in the community.
When I got to the ER, I just knew that I was at the end of my deck. I got hooked up with a real good doctor that day, and I was able to tell him everything and be honest with him about my drug use and my addiction. He was just the nicest person. 1, he made it easy for me, and 2, he didn't judge me. And from there, just was golden, I'd say.
Our patients are very much the ones that fell through the system. We see people that are at their lowest low, and oftentimes we forget that there's a person in there that has so much to offer. They just want hope, and there's nothing in this world that can change their mind outside of somebody caring.
I feel like with Brian in particular, he didn't make me feel uncomfortable. He didn't judge me. With somebody that you know that's been through it, and they can give you real insight, advice, they can relate to almost anything you say, and they can also help you come up with a solution at the same time, all while not judging you. I feel like that's a recipe for success.
My role as a recovery coach is to meet with a patient and work with them on a peer basis in order to help figure out what social barriers are preventing them from a successful recovery.
bringing in peer recovery coaches has been hugely transformative. We often talk about them as being the human glue of the work that we do, because not only do they provide invaluable care to patients, but they also are sort of a living, breathing reminder every day that most people recover.
The difference that they make is that they're in recovery themselves. They've been in recovery for more than a year, and they have been trained to be able to help their peers.
Here, we bring our coaches in as full employees, fully trained and oriented to hospital practices, and yet they retain this other special contribution, their awareness of our community and what it means to live with these problems.
A doctor's always going to tell them, you know, just take this medicine and you'll feel better. They know what's available, but if they have their peers that are on their level telling them, they listen.
I can recall back to that day where I had Suboxone in my left hand and I had two pills of oxycodone in my right hand, and I decided to go with the medication. And from there, it's been quite a journey. And I remember texting Brian roughly about an hour, 2 hours after, I'm thanking him that I felt like that was just the start of it, and I feel like that was my breakthrough moment.
Sometimes I can get people to talk to me that wouldn't normally engage with anybody in the medical community. And if I can break down that barrier this week, then who knows what will happen in the months to come, years to come.
A lot of patients say, this is the first time I feel like I can do this. This is the first time that I feel like maybe, just maybe, I won't die.
We can do this. We can creatively respond to a public health crisis and meet the needs of people across the full sort of spectrum of who they are. And the real need is that we have the will to do that in the context of overdose.
I don't think we're ever going to cure or eradicate addiction, but I think we're going to see far less overdoses. And for every person that doesn't end as another fatal overdose is another person that is potentially getting their life back.
Okay, thank you so much, Jasmine. And in the words of Dr. Wakeman, we can do this. And maybe a good start would be sharing what we've learned so far. So Maureen and Cindy, let you take it away.
Thank you, Kelly. We start by going through some of what we've learned through the Shift Care program for just a few moments. And we're here today to look at implementation and talk about helpful strategies for implementing opioid use disorder treatment in the emergency department. We've learned that it's really important to identify opportunities for treatments in settings that have in the past been somewhat non-traditional, but where patients can be reached. So let me start out by thanking all of those that were involved in the Shift Care Challenge initiative. All of the awardee hospitals in particular, I know it's you're not in the business to provide data for analyses, so thank you for all of the efforts you put into this. We want to thank the Health Policy Commission and the Department of Public Health, who provided data for us as well to look at the impact of Shift Care. So just to provide some additional context, opioid mortality, related mortality remains a serious public health problem. This is data from Massachusetts. You can see since 2000, overdose-related deaths have increased dramatically, and it continues to be a problem. Nationally, 73,000 deaths from opioid-related causes were reported in the year ending last August. And so why do we focus on emergency departments? We have found in Massachusetts in particular, mortality following emergency department visits for opioid-related problems is high. 5% of ED patients with an opioid overdose die within a year in a study that was done a few years ago in Massachusetts. And although mortality is 60% less for individuals who are receiving medications for opioid use disorder, less than a third of individuals seen in the ED nationally following a non-fatal overdose do receive these medications. Research indicates that initiation of buprenorphine in the emergency department has led to increases in treatment engagement after the visit, a reduction in illicit opioid use, and decreased use of inpatient addiction services. Consensus statements have repeatedly supported use of initiation of medications for opioid use disorder in emergency departments. So there's a lot of reason to look to EDs to help address the problem. So through the shift care investment, emergency departments were provided support to initiate models based on the model first developed by Gail D'Onofrio and colleagues at Yale University. And that essentially is identifying patients who are appropriate for receiving treatment or may be interested, approach those patients for treatment, initiate medications, and engage directly in outpatient care after the visit. Get patients settled, communicate with outpatient providers so patients know where they will be followed up. It involves a wide range of settings, beyond the ED, practice sites in the community, the emergency department, and other hospital departments, and outpatient care provided after the services in the ED. As you saw, the shift care cohort hospitals represent a wide range of regions of Massachusetts and a range of models from community hospitals to academic medical centers and ACO members. So the hospitals initiated their own models, and you're going to hear about those shortly, but there was a wide range of regions, hospital types, and models. We were asked to assess the impact of the shift care opioid use disorder initiative, and we looked at medication rates. You'll be hearing more about that, medication initiation rates, engagement in treatment, outcomes such as hospital utilization, mortality, and overdose. And we also looked to interviews with patients and staff to learn about factors related to program success and the true patient experience. I'm going to turn to Maureen Stewart now to talk in more detail about some of what we found that may be important as lessons and helpful to others in initiating programs. Maureen?
Cindy. So we used a mixed methods approach to conduct a comprehensive evaluation of the shift care investment program. We had 3 goals for the evaluation. We first wanted to examine the reach of the shift care model in terms of medication initiation and treatment engagement. So how many people were initiated and how did that change over time? Then we wanted to examine the effectiveness of the model in terms of changing ED utilization, hospitalization rates, and overdose to the extent we could track that. And then finally, we wanted to understand the provider and patient experience with the model. So we used data collected by awardee hospitals for the quantitative analyses, and our team conducted interviews with providers and patients to assess their experience. For the quantitative analyses, we conducted descriptive and interrupted time series analyses. Our baseline period prior to the shift care intervention was 3 months long, and then we followed the experience over 18 months after shift care started. To assess patient and provider experience with shift care, our team reviewed documents from awardee hospitals and had nearly 100 conversations with patients and providers. Next slide. So we found that OUD medication initiation rates increased over the course of the program from almost 6% prior to shift care starting to 11.6% of patients receiving OUD medications after shift care began. And this was a statistically significant difference. More than 1,000 people were started on OUD medications after shift care started. In analyses by different patient characteristics, we found that patients were more likely to initiate in the ED when they did not come in for an overdose, when they had stable housing, and when they reported having previous treatment for opioid use disorder. We also found that people who were Black or Hispanic had lower initiation rates. Next slide. So starting medication treatment is a first step, but it's important that patients continue medication treatment in the community. So we looked at community treatment engagement rates at 30 days all the way out to 180 days following treatment. And we found that almost half of patients remained engaged in treatment at 30 days following their ED initiation. This rate declined over time, but still at 180 days, more than a third of initiated patients remained engaged in treatment. And this is similar to other analyses of treatment engagement rates, and may be an underestimate because we could only track patients when they remained in treatment in the community organization that the emergency department had relationships with. If they changed to another outpatient program, we wouldn't be able to see them. Next slide. We also looked at ED revisits, and we found that there was an immediate increase following shift care, but then a decline over time. It's difficult to interpret this metric. Increased ED revisit rate could be a sign that patients feel like they're welcome in the ED, more welcome than they were, and that they're getting the care that they need. We did not identify any statistically significant changes in ED visits overall, in mortality, or in overdose following shift care implementation. I'll turn it back to you, Cindy.
Thank you. I'm going to talk for a moment about the qualitative findings. First of all, we found that buy-in and education of the staff is incredibly important for success. We included the hospitals included cross-functional teams, nursing, pharmacy, information technology, and clinical departments in the hospital in the development of buprenorphine dispensing protocols, and that was very much key to success of the programs. Anti-stigma efforts are also quite important. Stigma exists at many levels in the healthcare system, and it really impedes successful implementation of any program. The Shift Care program, according to interviews, made a notable change in the presence of stigma in the ED through the education and experience with patients and watching them respond to treatment. You've already heard a little bit about recovery coaches, but repeatedly we heard both from staff and patients that the recovery coach was very important for patient experience. They forged meaningful relationships with patients and made them feel more comfortable with their hospital experience. And they were reported to be very influential in recovery journey of patients. Recovery coaches also helped rebuild trust patients needed to have in the medical system in order to continue on recovery. Also, we learned that hospital resources are not alone sufficient to treat the many complex needs of patients. Just as in medically complex patients, these patients often had medical, economic, and social histories and circumstances that were very challenging. They may have basic unmet needs like food or housing that impede their ability to begin or stay in treatment. So it was very important to understand the lives of the patients who are being treated. Connection to community-based services was also another thing that we really focused on and recognized as incredibly important. One very critical reason is that providers feel more comfortable prescribing a medication for opioid use disorder, such as buprenorphine, if they know their patients will be receiving follow-up care. We heard this repeatedly from staff and clinicians. Then bridge clinics, or sites that provide outpatient treatment until patients can access community-based care, are really valuable to support retention in treatment. And finally, the emergency department is only one part of a much broader systemic effort for medication treatment of opioid use disorder and patients with other addiction disorders, and very valuable component, but it exists within a larger system. So you're going to be hearing from several of the awardee hospitals, but just let me say that most all continued the Shift Care program through additional investment by the hospitals, as well as outside investment and a culture change that has been sustained. And you'll hear about how that has been occurring. Finally, I'd like to close by including one quote by a staff member that really is something that we heard over and over again. Through the efforts of the Shift Care team, frontline staff now see opioid addiction as a treatable disease. So the Shift Care program served many purposes. Educating staff was a primary factor that created a sustainable change in hospitals. So now I'd like to begin our panel discussion by having each team share about a 5-minute summary of their Shift Care model. Stop sharing. Of their Shift Care model and highlight their major components like bridge clinics, how patients are identified, recovery coaches, etc. So maybe I'll turn first to Leahy, Sheila Laffey, and Karen Hassler from Leahy system to talk about your program a little bit.
Thank you, Cindy. I'm Sheila Laffey. I'm the program director for the high risk intervention team at Beverly and Addison Gilbert Hospitals, that are part of the Beth Israel Leahy system. And Karen Hassler is our addiction PA, who is part of the program. She's really been instrumental in the success of this program. So really, our program was to expand access to opioid use disorder treatment by providing eligible patients in the emergency department with recovery coaches and clinical staff who would assess their willingness and eligibility to begin medication for opioid use disorder. Patients seeking treatment are able to be discharged from the ED with a 3-day kit of buprenorphine and a patient instructions for home induction. And then they're connected to our bridge clinic, which is through Beth Israel Leahy Health Behavioral Services. Even if patients didn't get a kit, when they were identified as having opioid use disorder, they still received a phone call from the recovery coach on the program just to see if they could support in any way with their recovery journey. The recovery coach followed all patients with opioid use disorder for at least 6 months to support them on their recovery path, whether it was MAT, detox, IOP, other recovery resources, or harm reduction. Our staffing consisted of our addiction PA, Karen, for the hospital, and then we had a prescriber, a program manager, and recovery coach that was part of the bridge clinic. We trained all the physicians in the ED to get their DEA X waiver, which was required at the time. We also provided training for all of the ED nursing staff on COWS, as well as just addiction in general. Our bridge clinic was an existing OBOT already at BILH in Gloucester. And what they did was they carved out time, dedicated appointment times for anyone who received a kit in the ED. And then our addiction PA, Karen, was really instrumental in bringing a presence in the ED to just facilitate this process, to remind the providers that this process existed, to help them through, ease any fears that they might have had about prescribing a kit of Suboxone. And she actually also was a very good bridge to the bridge clinic. So she helped connect a lot of people to the bridge clinic. We had an external program that alerted us when somebody with a history of opioid use disorder presented to the emergency department, but we also watched the ED track board because sometimes people don't have a documented opioid use disorder diagnosis on their record. So the staff would, or still does, watch the ED board. If anyone comes in that looks like they would benefit from a kit, or if we get an alert that somebody is here, then the staff will respond to the ED to help facilitate and start that relationship with the patient. And then if a kit gets given after hours, we actually get an alert so that our team can then follow up with the patient and connect them to the bridge clinic. It's typically the bridge clinic who does that follow-up later, but it could be anybody on the team. Then we had our ED chief, was instrumental in making this a seamless process for the providers. He helped to develop an order set in Epic, so it was more of a one-step process rather than having to go through a bunch of different screens. It's just made it easier for the provider and made it more likely that they would go through this process. And honestly, the program has worked extremely well and continues today with a few adjustments. Our Bridge Clinic no longer has dedicated slots for patients who receive a kit, but they've moved to having walk-in hours. So they have plenty of options for our patients to be connected to them because they do allow for walk-ins. The recovery coach position that was for the Bridge Clinic, that was not sustained, but we do have our high risk team at the hospital that has recovery coaches on that team, and they will fill in and follow patients who need to be followed. Yeah, sorry.
Thank you, Sheila. And I noticed we're getting some questions in the chat. We're going to address those questions after the 3 introductory talks. So thank you. Anything else to add?
I was just going to add that we saw a gap in our service as we were doing it, that inpatients were not getting kits or not in that process. So we then developed an addiction consult service so that we could address those. And that's really it.
Thank you. Thank you, Sheila.
Sure.
Why don't we turn to Maria Quinn from Holyoke to talk about your program a little bit.
Absolutely. Thanks so much for having me here. My name is Maria Quinn. I'm a psych NP at Holyoke Medical Center. I feel like I could just say ditto to everything that Sheila just shared because they're very similar interventions with, definitely our own nuances. We had developed a flag system for our emergency department to identify folks and then do a chart review. We brought in recovery coaches and had them actually located within the emergency room, side by side with nurses, clinicians, other providers. That really, really helped a ton. We worked with our call center and navigation team to, identify anyone that we may have missed or anyone that they did follow calls for anyone that presented to the ED anyway. So when they would call the next day, and a lot of times we would have patients funneled to us that way as well through the follow-up call. We also started take-home Narcan during this time out of the emergency room and all of the medical floors. And we have an OBAT located within the hospital. So it was an easy referral for continuing view. We did not have view packages like the 3-day that Lady was referring to, but we were able to get folks started next day. We had walk-in hours. And really during this time, we identified a lot of things, but one of them was really initiating connections for other options for MOUD. So that's a very quick snippet of a ton of work that happened.
Thank you, Maria. Thank you very much. And now let's turn to Elizabeth Powell and Sarah Wakeman at Mass General Brigham. Can you talk a little bit about the program?
Sure. Yeah, I think a lot of similarities, and so great to hear from Sheila and Maria about their programs. Prior to Shift Care, we had a Bridge Clinic already, which had been really instrumental in us being able to partner with our emergency room colleagues and hearing from them that one of the biggest challenges is figuring out a safe and immediate next step in care for people who presented to the ED with substance-related health conditions. And so on that framework, we're able to expand our Bridge Clinic hours. One of the challenges we often hear from the emergency room is they're a 24/7 operation, and patients obviously come in at all hours of the day. And so thanks to Shift Care, we could expand to evening hours and weekend hours to be able to offer more availability for walk-in and for warm handoffs from the ED directly to Bridge Clinic. And so that allowed increased access, not just to medical providers, but also to recovery coaching, resource specialists, and then front desk staffing to make sure the clinic could function. In the ED itself, we built upon a nurse practitioner champion who already was there and was an expert in addiction, and added on a medical assistant and a recovery coach who could be a part of sort of an ED SUD care team that could serve as local champions and partner with the ED providers that were seeing patients. And they could offer support around diagnosis and treatment. They could help support ED buprenorphine initiation for providers that were newer to that care model. And we also had input from a clinical pharmacist and toxicologist who's a part of our champion team. We focused, because unfortunately the X waiver still existed back then, a lot of time and effort in getting people wavered. So we got 95% of our emergency department attendings wavered to prescribe buprenorphine, and had a sort of system of trying to celebrate the successes of people. Because I think one thing we'd heard was that emergency department clinicians often only see people in moments of crisis. So they don't see the success story of what comes next. They see the person who comes back and still isn't doing well. And that becomes sort of the image they have of what substance use disorder trajectories look like, when of course this is a very treatable condition with actually good prognoses. And so we started sharing stories of patients who connected to Bridge Clinic and what happened with them back to the ED team, and they would present that briefly at the start of faculty meetings to sort of call out the person who'd written that buprenorphine prescription or given that bup-home dose kit to really celebrate the success and the importance of that moment and touch point and linkage. And we met monthly and still do with our ED colleagues and what we call our sort of ED SUD risk rounds, where we would review how many buprenorphine kits had been given out in the past month. We would see what had happened to those patients, how many had linked to Bridge and had stayed connected to Bridge, and sort of track outcomes together to think about opportunities for improvement. If there was a month where things were a little bit slower, to try to understand why that might be, or if a person had been, sent out overnight and told to come back the next day and they didn't make it, trying to figure out sort of any opportunities we could to improve engagement. We created a clinical decision support in Epic, which is the electronic health record we use, that would identify patients that had opioid use disorder that hadn't had a touch point with Bridge Clinic, and would suggest to the provider not only to give a buprenorphine take-home kit, but to also put in an ambulatory referral order to Bridge Clinic and Epic. And the reason for that, since Bridge Clinic is a walk-in clinic, you don't really need a referral, but it actually created then a queue that our Bridge Clinic team could actually do outreach and phone calls to people if they didn't show up. So for folks that never made it, then we could do outreach in the coming days to try to get them connected back to us. And we would track those along with those buprenorphine kits that went out. We also were able to use the funding from this grant to support a partnership with Boston Healthcare for the Homeless program around people experiencing homelessness who had opioid use disorder, recognizing that because of competing priorities and trauma and being unhoused, buprenorphine alone and initiating buprenorphine by yourself on the street can be really tough. And so we connected to their medical respite program, Barbara McGinnis House, and were able to get people who needed it connected directly from the ED to medical respite, where they could do their buprenorphine initiation there, and also connect to a recovery coach that was a MGH recovery coach embedded within the medical respite program and could support them during their medical respite stay. I think all of those pieces together, really allowed us to build out this model of trying to engage with as many people as we possibly can and utilize the emergency department visit as a touch point, a reachable moment to engage with people. I think we've learned a lot, despite all that effort. There are always challenges, and you guys already presented some of those. I'm sure we'll discuss more in the conversation. I think we also have heard more and more in the era of illicitly manufactured fentanyl that we need more than just buprenorphine. So I think building off the scaffolding of this have created some direct transfer to opioid treatment programs for methadone from the ED, which was kind of a spin-off of what we learned in shift care, really, that we wanted to be able to initiate methadone and then connect people directly to OTP from the emergency department too, as the next phase of this work.
Great. Thanks, Sarah.
Wonderful. Thank you, Sarah. Maureen, do you want to start with some questions to the panel?
Sure. So all of you described a variety of different activities that were implemented during shift care, and there's some similarities and some differences in each awardee hospital and how they did things. If you're thinking about this from the perspective of a hospital who wanted to start a similar program, can you give a sense of what the key ingredients are that were, necessary, the basic requirements to operate a successful program? Whoever wants to take that.
I'll say something.
Thanks, Karen.
Hi, Karen Hessler, PA Addiction Medicine at Beth Israel Lahey Health, Beverly and Addison Gilbert. I would say that our key connection was that we had really strong administrative hospital leadership buy-in. They were really on board with this program, and they've continued to be on board with us and really championed the program and helped us build the addiction consult service from the ED buprenorphine program. So that has really been the number one thing, is we have not reached a single roadblock with our administrative leadership. It's been great. Yeah.
I'd echo that. I think having senior leadership, both at the department level and the hospital leadership level, saying this matters and we value this and we're committed to this is really, really important. I think the other part that was so important for us and continues to be is having bridge clinic access. I think without that, it would be much more challenging to support our ED colleagues in initiating treatment if they weren't sure where to connect people to. And so having that sort of, you can just walk in anytime, walk over right now, come tomorrow, open door model, I think really helps.
I think a lot of working closely together between the bridge clinic and the ED teams too, having like a handful of people who are getting together regularly, because I think a lot of what we did was brainstorm challenges and kind of work through really, specific workflow issues that would come up again to kind of achieve, to Sarah's point, really low threshold and immediate access to services that would kind of reinforce for ED providers the access to care that we do have and the kind of resources that we have to treat people. And in order to do that, we needed to make sure it was really easy and that it worked really well. And so having that commitment from people on both sides to work together to problem solve those things was important.
I think we have a question from the panel, Kelly, to the panel. So can you say a little bit more, Karen, perhaps, and others, about how you actually get that buy-in from the administration? We all know that's key. How do you do it?
Yeah, we had a lot of one-on-one conversations, honestly. I spent a lot of time walking around the hospital talking to people. I was kind of a new face in the hospital, so people were like, oh, hey, how are you? Who are you? And I would just have conversations with anybody and everybody who wanted to listen. So it's a lot of just one-on-one conversations. And also, our hospital as a whole has a really community impact mission, and we really take seriously our role as community health providers. And so for our hospital leadership to continue on that road and really embrace the substance use community was really, really helpful, because they realized that was an underserved member of our community. And for them to say, oh, great, now we have a team and we can really address this situation. I think it was really helpful. A lot of providers also really liked having the support. So it wasn't hard, because we really added a lot of value to a community they already knew was underserved, and I think weren't really sure how to serve them.
I think I can add a little bit just in terms of from Holyoke's perspective, how we work with buy-in. There was a lot of different activities that we did, a big kickoff meeting with all of the stakeholders, frequently meeting folks, but I think also for me at least was recognizing that I needed some patience, and that there's just like years of ingrained stigma and bias that I'm now bringing to, which includes providers. So leadership is on board, providers are on board, but they also have these, their own perceptions that they came to the table with. So I can have great, a lot of money behind me, which is always nice, and great staffing, but there's a lot of work to undo a lot of things that, people have been practicing under. Things like you're coddling this person, which has significantly changed, but it was really figuring out how to not just get the buy-in, like, yeah, Maria's here to help with that, but understanding kind of what was going on. So the challenges were also helpful in identifying what to address in the future.
That's great, Maria. You mentioned kind of stigma as one of the barriers that you faced in implementing this program. Can all of you talk about different obstacles you encountered and how you may have overcome those obstacles?
Yeah, I will start with one. We had the DEX waiver obstacle, because back then we still had to have the DEX waiver, and getting providers trained when they were a little bit uncertain about the whole process was one barrier. I distinctly remember somebody at a higher level saying, there's no way you're going to get everybody trained. It's not going to work because you're not going to be able to get all of these providers trained, which was just what we needed to say, oh yeah, watch us, we're gonna do this, we'll figure out a way. So in addition to Karen's kind of one-on-one training with folks and talking with them about it, we actually were able to, through the Shift Care, we were able to offer some stipends to get the providers trained, and that actually worked well. That really sealed the deal for us. Most of the physicians were jumping right on board to do it once that they knew that they were getting a stipend, and we were able to bring the training to the hospital. So it was pretty easy for the physicians to get trained, and that was helpful. We had a few holdouts that waited to the very end, but we did end up getting 100% of the physicians trained. So that was huge.
And then to add to that, the ED medical director made it a condition of employment for all new physician hires. So they had to be ex-waivered in order to be brought on staff as ED physicians. So that was huge.
I think that we have found sometimes that sometimes stigma comes from a place, especially with providers, of feeling hopeless about what they can do for patients. And so I think a huge part of and this is a challenge in a large and busy ED, but as much as we could work on sort of educating people, again, getting waivered and being able to prescribe and offer medication for treatment. And then also, resources like referral to Bridge Clinic and recovery coaching, and sort of a menu of options that people could offer and feel like they could actually do something for that person who is in front of them, I think was one way that we could actively combat the stigma.
You. The Shift Care program took place during the early months of COVID. Started in 2019, and COVID really was declared an emergency, a public health emergency, early in 2020. Do any of you want to talk? And I know that you have all maintained your programs throughout that period, perhaps returning to telehealth. So I have a two-part question. How did you maintain activities during COVID? And also, what are your experiences with telehealth, and have you continued to engage patients remotely? Sarah, do you want to take that? I see you're shaking your head.
Sure.
Yes.
Yeah, I think, we pivoted as quickly as we could to first incorporate telehealth, which is something we really hadn't done any of in Bridge Clinic beforehand. And then to get back in person as soon as possible. I think from the start, we felt it was really important to offer multiple different ways to access care. And I think the expanded telemedicine flexibilities, particularly around initiating buprenorphine via audio only, and having options around audio or video or in person, were really important. There definitely were some patients who either, really needed and wanted that human connection of coming in person, or despite efforts at trying to help them access a phone or a tablet, were not able to connect via telemedicine. And so having that in-person walk-in, drop-in model continued to feel really, really crucial. We were fortunate to get a small philanthropic gift during the pandemic that allowed us to buy some tablets for patients. And so we would give those out so that people could connect to us via telemedicine if they wanted that as an option. So that was really helpful, as many of our Bridge Clinic patients and patients coming to the ED with opioid use disorder, as I'm sure many of yours are, dealing with poverty and other challenges, and sort of the digital divide is very real, especially thinking about racial and ethnic disparities in access. So having ways to connect with people was important. I think one of the hardest pivots for us was the flexible nature of our clinic had always been just show up, just walk in whatever state you're in, and we're going to be there, and you can have a cup of coffee. And all of a sudden you had to come, our hospital, there was all of a sudden only two entrances. You had to go to the desk, you had to have an appointment to be allowed to come in, you had to mask and go through a COVID screening process. And it was sort of the opposite of a very flexible walk-in, drop-in kind of model. And so we worked with security and our kind of, patient services folks to come up with a protocol where that if someone showed up and wanted to walk into Bridge Clinic, they would call back to us and we would make an appointment so that they technically had an appointment so that they could come in despite the COVID restrictions. But I think we all worried that, patients who were going to have the most challenges coming into systems of care were probably least least well served with the added restrictions around COVID. But I think the team did their very best to try to maintain that kind of walk-in model while also adding telemedicine. And then we've continued telemedicine, I think much less than at the height of the pandemic, but being able to, again, offer that as one of many low barrier ways to connect to care has felt really important. And so, you know, there's still definitely some telemedicine that's happening.
Great. Any others want to talk about remote, or why you might not have adopted it, or what you did during COVID?
Very similar for us at the hospital as well, where we use telemedicine, a lot more telephone, to be honest, because most folks did not have access to either Wi-Fi or anything that would enable or allow them to use video. We started doing things like having intakes from the Bridge Clinic, like when folks were at an APS. So that was nice, not something we've done in the past. The emergency room definitely slowed down for some time. We were fortunate because of the grant that continue to have the recovery coaches. Some staff were definitely deployed to other areas just based on need within the organization, but overall it continued just, you know, differently. I think if anything, it really showed how creative we could get in terms of continuing to provide care.
I think our data did show that quite a few of the hospitals used telehealth during COVID successfully. And it was a great resource for several of them. Maureen, did you have another question you wanted to pose to the panel?
Sure. We were going to shift to talking about how you're sustaining the programs after Shift Care ended, and what modifications you've made and how you've potentially gained buy-in for continuing this after the HPC investment ended.
I'm happy to start with that. So we were fortunate enough to get another grant after Shift Care ended to help us continue on. We really found that giving the kits in the ED and connecting them to the clinic kind of became hardwired. So we didn't have to focus on that quite as much. But I think I mentioned earlier that we did notice a gap in service and that people who were inpatient did not get the opportunity to really get initiated or get a kit. So we realized that that was a hole. So we started the addiction consult process, which actually Karen started it. So I should probably let her be talking about this. But with the funding that we got from the Healing Community Studies, we were able to get that off the ground. And having that in place, in addition to the kits, Karen's just become an invaluable part of the team, and the hospitalists rely heavily on her. And I think somebody else mentioned earlier about the providers now have an option, like they have something they can do now for these patients. Whereas instead of being frustrated and thinking, I don't know what else to do, now they at least have the option of calling Karen, and she's been able to educate them on not only starting on buprenorphine, but on methadone and just other managing pain while people are taking methadone. So it's just sort of grown on its own and just become part of the team to the extent that I could then just put it into the budget for the following fiscal year. So it was one of those no-brainers. We even had the CMO was like, if anybody gives you a hard time, you let me know because we need this service. So it really just speaks for itself when you can actually care for patients that need it. I don't know, Karen, if you want to add anything to that.
I don't have a whole lot to add. It was one of those things where it felt like if you build it, they will come. It was like we needed to do this. And so it really built organically. I just started going up to the floors and talking to the hospitalists about patients that I identified on the hospital board that could possibly use addiction services. And when they their eyes sort of lit up when they saw that there was somebody that could teach them something about it. And they, it was pretty much like every hospital or most hospitals were doing then. And that was sort of ignoring the addiction part of their medical picture. And so I think it was really empowering for them to not do that anymore, and to understand that if they had questions, if they needed backup, if they needed anything related to the patient's addiction, that they had a resource. And so it started out with just conversations, and then we built a opioid withdrawal order set in Epic. And so now it gave them off hours. So when we're not in the hospital, they have options to be able to order an opioid withdrawal order set within Epic. And so they can do methadone and Suboxone inductions or methadone tapers without, if they don't have the option of the consult service. Most people want to use the consult service, but they're happy to be empowered off hours now too. So it just sort of was boots on the ground kind of organic growth.
So not only did you sustain the program, but you've continued to expand and grow it. So that's really great to hear. Did you have something you wanted to add, Sarah?
Yeah, I think, you know, the idea of building it, and they will come in terms of providers wanting this as a resource or just generally running addiction services for their patients, I think is so true. And, you know, separate from shift care, we saw this in our hospital addiction consult team, where we started out on, you know, 8 medical units and then gradually spread out across the hospital. And then it just becomes a part of practice where people are always saying like, gosh, what did we do before we had an addiction consult team? I think that's what you want them to feel. I think there's also challenges around funding in the post-pandemic era, I will say. So it's not all sort of roses, unfortunately for us, where, you know, healthcare systems budgets have been hit really, really hard by the pandemic. And so, you know, we're trying to expand back to evening hours, which was something that, you know, we had to, I didn't mention that, but had to get trimmed in the time of COVID. And so I think Elizabeth and I and our team, you know, are constantly thinking about what grants can we apply for, what, you know, opportunities are there to find more support and more services. And it is sort of a full-time effort to maintain that. So interestingly, I think the stigma and culture shift piece totally sticks. And then, you know, part of the challenge in this moment in healthcare is just how do you continue to fund needed services of all types, including substance use disorder services. I'll say one, you know, big win for us is, you know, as our system, you know, has come together as Mass General Brigham, we now have expanded to have 4 bridge clinics across the system that can serve anyone. Actually, you don't have to be an MGB patient, but also the entire MGB system. And so that's been really neat to see the model that started at MGH then get spread more broadly, and to try to take this idea of utilizing touch points like emergency department encounters from shift care or people walking in off the street as an opportunity to initiate treatment and help people stay connected to care.
Thank you. I think this is a testament to you all, because so often we hear that investment programs are time-limited pilots and the activities when the funding ends, and you all have been really successful, although it's not easy, as Sarah brings up, but you've maintained your programs and expanded your programs. So it's a really good lesson for programs.
Can I just add one thing?
Yeah.
One thing we were able to continue also is our relationship with the Bridge Clinic in Gloucester. So, you know, we joined forces with them through this grant, and then once the grant ended, we had a relationship with them. So we continued, and we continue to this day meeting weekly with them to discuss patients. And so it empowers us as a hospital system to have a place, a resource to send patients to once they're discharged. So that's been really valuable to be able to maintain that.
I think in terms of Holyoke Medical and how we've been able to sustain, we also were recipients of the Healing Community Study. And so with that money, I asked for a nurse and to continue to have our recovery coaches. And really, I think one of the things I was noticing, which is exactly what Shirley was saying, is you're missing folks on the inpatient, on the med floors. And figuring out how to address that. One of the things I didn't want to do was be a provider specific program. So like as Karen was mentioning, having the order sets, like if I wasn't there, I wanted to continue to have things done. When we started the consult service, we quickly realized, you know, I know there's patients here. We see the numbers. Like our first month we had 3, and then 3 consults. And then quickly now we're at between 130 to 145 a month, which is exactly where, you know, we should be. What it's done is given resources to providers and nurses. We've really gone in there from the start where my addictions nurse does orientation for all the nurses. So they're familiar not just with the services that we provide, but also things like how, even though sometimes I feel like that's with fentanyl, but anyway, see what all, not just opiate use disorder, alcohol use disorder as well. We also developed a really close relationship with our 2 community OTPs, opioid treatment programs, so that we do direct admits from either the emergency room or the med floors, which is something that I'll tell you when I started with Shift never happened. I used to find myself almost begging clinics to be like, can you please get them in this week? They're discharging, they can't wait until next week. Where now, if that's just unheard of, we send over what they need and a last dose letter, and folks are immediately connected. So really Shift provided, I feel like, that gas, and really you allowed us to really see all of the different opportunities and gaps. And then we just continue to really build on that. But it's, our team continues. We have recovery coaches here every day still. I have 2 nurses, one for the bridge clinic and then one on the consult service, which, to be honest, I always joke about this. They don't call me anymore. They seek her out for everything because she's really developed strong rapport, has a good understanding of what is needed, and really gets things done. We have just, from the emergency room all the way to the inpatient and outpatient, it's a really, really great connection. So we're very, very fortunate that we've continued this work, but also that overall the organization has seen the value in it, really, for not just our patients, but our staff and our community. It's really challenging for nurses to feel like they don't have tools for some patients. So,
Thank you. Thank you. Any other comments on this? We have some excellent questions from the audience, so I'd like to turn to those. Jasmine, are you pulling up questions?
I'm here to do that,
Hi,
Cindy.
Taylor. Thank you.
Yeah, no
Why
problem.
don't you read out some questions to us, and we'll see who can answer.
Sure, sounds good. So just going in order here. Someone's interested in whether treatment the treatment only included MAT, or were there other supportive services like housing and food assistance? So getting a little bit into addressing some health-related social needs that may have arisen.
Any of the panelists have experience with going beyond the medications and medically specific?
We had a resource specialist. We have a resource specialist in our bridge clinic. It was partially supported by the Shift Care funds at the time, and has been able to continue, and hopefully we hope to grow that position too, because there's such a need. But we that person has, at least for patients who are referred to the bridge clinic, been able to support some of the needs beyond just medical care related to substance use disorder. So help with transportation and food insecurity and things like that, insurance challenges. So she's able to help with making some of those referrals and connections for resources. And then the other cool role that we have in the ED that I think might be new since Shift Care, although I can't remember exactly when it started, as an ED navigator role. And it's not specific to substance use disorder, but for patients who are eligible, that role is a navigator position that's able to support some of the social needs that people may have, especially this population when they're in the ED as well. So we've been in partnership with the department that oversees that role as well, to kind of give input around what the needs are of our patients.
Wonderful. Thank you. This next question looks like it may be a question for the Brandeis team, or I think y'all could answer this. So it's asking about, how does your retention rates compare to treatment as usual or the literature around opioid addiction treatment?
Sure. So we didn't have data on treatment retention prior to shift care initiating. We did compare our results with the literature and found that our treatment engagement rate is similar to other observational studies rates. It's lower than randomized trials of ED-initiated buprenorphine, but that's kind of to be expected. And our report to the HPC with tons of details and data is on the HPC website. So you can find that there.
One thing that challenges the response to this question is that there were so many models that were used in implementing the EDOUD program that it's difficult to say what components were most effective and compare directly across all the programs as one cohort. So it's hard to, because we didn't have an established, structured, specific way of approaching this, because we recognize these are different hospitals, different populations, different locations and stuff. HPC gave hospitals the opportunity to design their own programs that would work best for their own populations. So it kind of it makes it a little more difficult to compare exactly what our outcomes are to to trials or to other literature. But basically, when we reviewed the literature, as Maureen said, this is very much consistent with what we're seeing.
Great, thank you. Next question here. Does the Bridge Clinic require that patients change their primary care provider to the hospital where the Bridge Clinic is located? This had previously been a requirement and a barrier for those that had primary care that they were already happy with. So I'm not sure if anybody can speak to that.
I can say that our Bridge Clinic did not require that a PCP change be made.
Yeah, ditto. No, we've never had that requirement. I think it's important not to have that requirement. And also from the start, we felt it was really important that the Bridge Clinic be payer blind. So even if someone had an insurance product that, you know, wasn't contracted with Mass General Brigham, that they should be able to walk in and access the same level of care as any other patient. And part of the leadership support was the ability to do that, even though it meant writing off a lot of financial cost in the Bridge Clinic. And then depending on what was best for the person, either would connect them into, you know, long-term ongoing care at a site where they would be able to connect via their insurance, or if they wanted to stay with us, would help them change their insurance product. But really making it as easy as possible for people to access care.
Same here. We did not have that requirement. I think that and I'm not sure if it still does, but for several community health centers, some of which are affiliated with some hospitals, that was a requirement at one time that you had to have primary care there to get addiction care there. I know Holyoke Health Center has changed their policy around that. But just for us and our hospital, absolutely not, no.
Great, thanks everybody. Our next question is related to telehealth, which I know came up a little bit, but wondering if folks can share a little bit more about how telehealth was used in their programs, either during COVID or outside of that. And specifically, were there any successes or challenges in using telehealth?
I still work on several days per week on an outpatient basis, so seeing folks through the OBAC clinic. I really like having telehealth as an option for patients who have particular mobility issues, folks who are working and aren't able to make it during our office hours. Unfortunately, we don't have extended hours. I really hope to get that at some point, but that's really helpful for people who are employed, and I don't want to interrupt that to have them, you know, come in to be seen. It has really been just helpful in that way. To be honest, again, most of the time it is via telephone, not video. I don't know if that's everybody else's experience, but I have found to have the option helpful, and I have my first slot of the day is always blocked for that. mixing it in the middle of the day, I have found to be a little bit challenging, but starting off the day with the telehealth is nice.
Do you all see telehealth or telemedicine as a critical component now of your programs?
I think the
If we
goal
were to
always
go-
needs to be as many pathways to care as possible, whatever that looks like. And so telemedicine feels like one piece of that. And walk-in, drop-in care, I think, feels mission critical in particular to this model, but I think telemedicine has been a wonderful expansion.
Thank you. Taylor?
Great. Yes. I have another question here about the type of trainings that were provided to medical staff, and perhaps we can even extend this to, stigma types of trainings, even equity focused efforts. Yeah, what kind of trainings or opportunities did folks have for continuing education in these areas?
Well, because we had to do the waiver training, we would tweak the traditional teaching to have more of a sort of anti-stigma harm reduction focus than the traditional 8-hour content, although of course including the necessary content. And so I think that was always really nice, and often bringing a patient to share their experience, because I think again that narrative of this is an important touch point on the arc of recovery was really helpful in addressing some of the kind of nihilism and feeling of helplessness that can drive stigma. We also have Embrace Recovery Month at the hospital, and have each year had a series of events, including educational talks and panels by our recovery coaches, and lots of different sort of trainings throughout the month. And then one kind of keynote kickoff event where we often try to get a high profile outside speaker or expert, and have focus in particular on the impacts of racism and the overdose crisis and treatment outcomes in the past several years. And so I think that's been really important too. And again, to the note of like hospital leadership being so important, having some of our most senior leadership come to those events, I think sends a message that, we're all in this and we all think this matters, which has been really nice.
Outside of the X-waiver training that we did for all the ED physicians, we did a lot of nurse training too, and they were all equally happy to be able to have that kind of empowerment to learn how to use the cows appropriately, to learn how to talk to people with addiction in a non-stigmatized and respectful way, how to speak to people with non-stigmatizing language, things like that. So a lot of what we did is, we did a little bit of training sort of during their shift huddles, like at the beginning or the end of their shift huddles, to try to get people. We would try to get as many people as we could by sort of coming on the cusp of shift change, which is really difficult. So it was nice that the nurse managers from the EDs really opened up some time for us during those period of time, so we could get both like evening people or day people in one talk. So we did that kind of stuff, and they really had a lot of questions, because again, it's just the empowerment and being able to learn that they do have power to help people that are in that situation, and that it doesn't have to continue to be a revolving door for that person, that there are pathways to treatment for them. And that helped them really want to start to help people, so they could sort of stop that revolving door feature of the ED.
For us, well, first I just want to say that I hope I get an invite, Sarah, to your kickoff event for Recovery Month, and whoever your keynote speaker is going to be this month. That sounds really great. So yeah, education. I think I had mentioned before that we had done, we do orientation trainings for the nurses. Another training that I did was pain management for folks with opioid use disorder, where I had somebody come in and presented to the hospitalists around this, because I was finding that sometimes there's a lot of questions, and we did a lot of advocacy in terms of pain management, appropriate pain management. We made a video. It was actually created geared towards the ED nurses, but really we've been using it throughout. It was around harm reduction in the hospital setting and really how nurses can discuss with patients, empower patients, feel comfortable with talking about using drugs and alcohol in a safer manner. A lot of educational sheets and handouts, all of that. The education part has been really fun, especially when you see the change. Small changes for us, which are really actually big, is seeing things like opiate use disorder instead of substance abuser and heroin user. Patient, to be seen by recovery, or patient seeking, admission for treatment as opposed to wants to go to detox or, things like that. Those are the things that get me excited when I read a note and I'm like, ooh, this is really like nice, non-stigmatizing language. And like, it makes me want to jump up and down, but those are the changes that I think for me are really, really important and trickle down.
Great, thanks so much, everybody. A straightforward question here, and I encourage other folks, if you have questions, to submit them through the Q&A chat. But I think pretty straightforward. Is your ED program billing Medicare, Medicaid, or private insurance for the services and staff time?
I don't get heavily involved in the billing side of things, but I know that certainly any of Karen's time is billed through the hospital services, and we're billing. I mean, the ED is definitely billing. Most of our patients are Medicare, Medicaid, and private insurance. So it's my understanding that all of this is being billed.
Yeah, we also bill for all billable services. I think that some components of this model are not billable. Especially if you think about things like resource specialist support. And I know there's a model for billing some recovery coach services, but not everything there is billable as well. So there's different components that are not billable but for anything that is, we definitely do bill for those services. And like Sarah said, have set up for the bridge clinics some particular financial arrangements and understanding about write-offs that may need to occur for people who don't have insurance that we're contracted with, or as a result of our policy to be open to people payer blind.
Thank
We did learn from national research we've done with case studies that the coverage for navigators or peer support was quite inconsistent, and was one of the very difficult components to maintain and to sustain after pilots. So I think in a lot of cases here in Massachusetts, I think that it's been addressed, but it is still not consistent across payers and across programs.
Great, thanks everybody. And Cindy, as we're approaching kind of the last 10 or so minutes, thought I'd toss it back to you for your closing questions for the panel. Thanks everybody.
Well, thank you for all these great questions. So I'd like to just turn to the panel and ask you in the last few minutes, what would you suggest for some pearls for anyone starting or maintaining a program to initiate treatment in, or for OUD or other a substance use disorder in the ED? So maybe I'll turn to Sheila first.
I think this is kind of a squishy topic, but to me, having the right team in place and having people that are truly dedicated and wanting to help this population, because I think you've heard that some of us have faced some challenges getting this started and even continuing it. We sometimes still face some stigma along the way, and you still face some uphill battles. And honestly, if we didn't have the right staff in place that didn't mind those uphill battles and didn't have the tenacity to keep going and the perseverance to just say, I'm going to get this done, and we're going to talk about this over and over again until we get through to everyone. So I think that is one of the key components for our team. And that's just, yeah, it's one of the things I usually stress and strive for on the team is that right type of person who's willing to go the extra mile to make this all work.
I would add to that, outside the team is to find the champions within your hospital that may not be on your team, but you can recognize pretty quickly the people who really are interested in learning more and interested in sort of spreading the word on how to treat people with substance use disorder. So sort of really working with them and identifying them to get them on, your informal team of treatment providers.
Add to that, I think I've often come to think of it as like motivational interviewing for systems, that rather than telling the disbelievers and naysayers what they should do, figuring out sort of how our motivations align. And often there are goals that are shared that we can work towards, whether it's around value of healthcare or capacity challenges or provider burnout, or community health and mission, whatever it is, to try to figure out what is the sort of lever of change with this particular stakeholder. And then I think we also want to make it as easy as possible for patients to access care and as easy as possible for providers to do the right thing. And so there are ways to kind of design systems, think about utilizing electronic health records to be helpful, all of the kind of operational pieces that make both of those things easy so that people aren't having to work to do the right thing, but rather becomes the default and the thing that they naturally go towards.
Low barrier entry for providers as well as patients. Yeah. Anybody else?
I echo what everybody else said. I think the other thing is don't be afraid to find mentors and ask people how they've done it and what's worked for them, and tweaking order sets and policies and procedures to meet your own organization. Champions for sure, Karen, that is like so key. Like-minded folks, you definitely, those will start to come out. And like Sarah had said, I think a big reason a lot of this works is I just say, like, just be nice. We're not going in there to, butt heads and challenge but it's be nice. At the end of the day, our goal is to ensure that patients are getting great care, compassionate care, and that they feel comfortable. And no one really likes to be challenged or told what they're not doing right. It's not always what you say, it's how you say it, of course. So that's the biggest thing. And be, patient and with yourself in the process.
Thank you. So would anybody on the panel want to add anything before we turn back to HPC? I think we've touched on a lot of areas and got a lot of great questions from the audience. I just want to say, for the Brandeis part, our experience was wonderful, experiencing a lot of incredible commitment on all of your parts to engage and do the best, implement the best program possible and continue way beyond what you were originally committed to. So thank you all for that. Kelly or Taylor, do you want to?
I think I get the pleasure of wrapping this up. So thank you so much, Cindy. First, in addition to thanking Cindy, let me thank Maureen and Taylor. Thank you, our moderators, obviously our panelists, and all of the people who participated in this webinar with their good questions and ideas for such a rich discussion. I also just want to take a minute to thank the HPC staff who supported the Shift Care Investment Program, and also to Taylor Bungo and Jasmine Bland, who is behind the scenes here, who did a lot of the work to make this event happen today. So thank you. I mean, I have one word for all of this, which is wow. And I say this as somebody who has had the pleasure of reading the evaluation report, who's learned a lot about these awardees over time. And it's interesting, the word that comes to mind every time I hear the people speaking about their programs in this space is scrappy. And I mean that as the highest compliment. And I love that where we ended today was on this notion of the right team and the right people with tenacity, because I think that's what it takes to get this done. And it's such a pleasure to see it in action. So we covered a lot of really important themes today. You know, I loved the conversation about leadership buy-in, and not just that it has to happen, but how it has to happen. And again, this is a great example. I know, you know, what we heard from Maria in particular and Karen about just, you know, lots of one-on-ones, lots of, you know, just time spent getting to know people. The detective work to find your allies in leadership was, I think, really, really useful. And obviously, I mean, I think the other thing that's really, really interesting to me is hearing today about the connection between that work and stigma, and how, you know, again, this notion of giving people, giving clinicians, giving leaders both a sense of obligation to provide support in this space, but also opportunity. Again, I've spent a lot of my career on the provider side, so I'm always fascinated to hear about provider engagement strategies. And, you know, this notion of motivational engagement with systems, I love, you know, which is like, let's try to find out not where we're in opposition and try to solve that, but let's find out where we're in alignment. I think was a really, really interesting theme today. And then the last, and I can't say the best because I thought this was all great, but just the notion of like, let's make it easy for everybody to do the right thing. And, you know, I hope that, you know, in addition to all of those good learnings, we can also do some really important work trying to quantify all the dimensions of value of this work, so that it can be sustained, and that, you know, there isn't the risk that this kind of important programming ends when the next grant ends. So, you know, we'll try to be allies in that. So, as I said, I think it's fair to say we learned a lot, and we still have a lot more to learn. So with that in mind, I just want to give the folks who are on the call a heads up that we're planning a second webinar focused very specifically on OUD treatment and racial equity. So we'll be sending out information about that next event shortly, so watch your inboxes. So again, many, many thanks to the attendees, the panelists, the moderators, and the team. Couldn't have happened without you. And with that, let me say thank you and have a lovely rest of the day.
Thank you, Kelly. Maybe before we go, each of the panelists could put your email address in the chat so that people can contact you for more guidance. Are the panelists able to use the chat? Great. And our report on the Shift Care program is on the website. Did you put that in the chat link?
I did, yes.
Yeah, let me make a, thank you for saying that, Cindy. Let me make a plug for the HPC website, because in addition to the evaluation report, we have awardee profiles, we have impact briefs, we have some deep dives into individual programs, and we have the video. And I wasn't kidding when I said up front that, you know, I can talk my head off if I want about these programs, but it's never as meaningful or as valuable as hearing people talk about them themselves, particularly individuals who've benefited from them. So that video is in the public domain for you to use if it will help you tell the story of this program and your work to any audience. So please make use of those resources. They are there for the public.
Thank you all.